Good morning, everyone. Welcome all of you joining the public presentation organized by the Manitoba Federation Labor Occupational Health Center. So today's the topic is immigrant home care workers in the Manitoba during the pandemic, the exploitation, precarity, and resistance. Today, we are so honored to have Dr. Jean Hande with us. She is the principal investigator of migrant care work and the geopolitics of aging in place during the COVID-19 pandemic and assistant professor sociology in Trent University. First of all, we would like to acknowledge that we are on the Treaty 1 territory, the traditional territory of the Anishinaabe, Greek, OG Greek, Dakota, and Diné people, and the homelands of Native nations. We respect the treaties that we made on these territories, and we acknowledge that we are treaty people. At the Occupational Health Center here, we commit ourselves to our process of reconciliation with Indigenous communities. So for the participation here, so please put your question in the chat box section in the right side of your screen. Dr. Hande will try to answer it after her presentation. And we may not be able to answer all questions. We will see how the time wise then, but please connect with us afterwards to follow up. This session, you can see, is being recorded for reviewing later and also share on the social media. So for some people that doesn't know the Occupational Health Center, we are funded by the Winnipeg Regional Health Authorities. We are the community health center here in Manitoba. We are located on 167 Sherbrooke Street, Winnipeg here. So we provide the services to the Manitoba workers with work-related health issues and work closely with the Joint Workplace Health and Safety Committees for training. And all our service is free. So please visit our website for more information and resources. Before I welcome Dr. Hande to do her presentation, I just want to read her short bio here to let me introducing her. So Dr. Hande is assistant professor in sociology at Trent University. Her community engaged research focuses on aging, disability, immigration in precarious work, continuing care systems, and struggle for social transformation. Currently, Dr. Hande's central focus is a SSHRC Insight Development Grant, which she meets with Migrant in Manitoba, exploring the policy landscape and experiences of immigrant healthcare workers during the COVID-19 pandemic. Her writing has been published in diverse venues, including Canadian Dimension, Input, Ethnics, and Geopolitics and Advocacy. So now please join me to welcome Dr. Hande. I'm going to stop sharing my screen.
Thank you so much for that warm introduction. I'll share my screen now. Hopefully it works all right. Can everyone see that?
Yes, it's all good. Thank you.
Okay, great, wonderful. Yeah, thanks again for the warm introduction. So I'm Mary Jean Hande, and I'm really honored to be invited to present to you today. And I hope we'll have a great conversation after the presentation. It should be about a little more than half an hour for us to chat. So I'll be watching the chat box for your questions eagerly. I wanted to acknowledge before getting started that I'm presenting on behalf of a team today. So I'm the project lead, but I've relied very heavily and worked collaboratively with an amazing team, Nelly Agbulos, Diwa Marcelino, Susan Rodriguez, Leah Nicholson, and Mehmet Yavuz. And I've also been working with people who have been really doing pioneering work in the migrant justice and migrant care work across Canada and the United States. So I want to recognize Ethel Tungoan, Jessica Dakar, Valerie Francisco Manchavez, who have mentored this research, and Migrant in Manitoba, who has partnered with us on this research project. So I also did a land acknowledgement. I wanted to acknowledge that I'm a white settler born in Treaty 6 territory in Saskatchewan, and today I'm presenting to you from my home in Toronto, the unceded Dish with One Spoon territory and the traditional land of the Huron-Wendat, the Seneca, and most recently the Mississaugas of the Credit River. And our research was based in Manitoba, so the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and the homeland of the Métis Nation. Our research has and community partnerships have really aimed to build solidarity across anti-colonial and anti-imperial struggles across Turtle Island. And I invite you, if you feel so inclined, to share where you're located in the chat today, if you're joining from outside of Manitoba, or any reflections on what the land acknowledgement means to you. So our case study is in the province of Manitoba, as I mentioned, which is it has a unique home care and immigration landscape in Canada. Like the rest of Canada, it has a rapidly aging population that has dramatically increased the need for healthcare services for older people. And healthcare worker recruitment has not kept pace with the demands of an aging population. Home care work, and by home care, I mean services that are provided in the home or in community, as opposed to long-term care residential facilities. This is really the overwhelming preference of most disabled and older people requiring ongoing care supports. But despite this, both provincial and federal governments continue to invest more than 80% of public monies to residential facilities rather than home care. So this remains a largely unfunded and unregulated sector, and home care workers' wages on average continue to be the lowest among healthcare workers. Manitoba is no different than most provinces in Canada in that home care workers are predominantly women, and a growing majority in Manitoba, over 60% of home care workers are racialized immigrants. These immigrant workers also incur what has been called a wage penalty. So they're actually paid, even though home care workers are kind of at the bottom of the pay scale, they're paid even less than their white or Canadian-born home care worker counterparts. So they're effectively at the bottom of the care work hierarchy and often lack the support in terms of health benefits and labor representation that other healthcare workers have. Additionally, most home care workers in Canada are employed in the private sector and work alone behind the closed doors of their employers or clients' homes. And there's often little recourse if they encounter problems in their workplace. So they often feel invisible and isolated. And particularly when it comes to media coverage of health work issues, policy, and general campaigns around the rights and resources for healthcare workers. Recruiting foreign home care workers through temporary foreign work channels like the live-in caregiver programs, which many of you have likely heard of, has been a popular option for families with the means to hire home care support for older family members. However, for a variety of reasons, this is not a common practice in Manitoba. Nevertheless, there's still a very long history of migrant Filipino domestic workers in Manitoba, actually among the oldest, longest history in the country. And live-in caregiver organizing peaked in Manitoba in the 1990s with the formation of the Filipino Domestic Workers Association of Manitoba, or FIDWAM. And I'll talk about that a little bit more later on. Manitoba is also unique in that it was the first to implement legislation protecting migrant workers in 2009. It was one of 2 provinces to deliver settlement programming and remove immigration status as eligibility criteria to access services, which changed in 2013. They also have a long history of NDP leadership and labor organizing, and Manitoba has the most accessible provincial, well, by some estimates, the most accessible provincial immigration program in the country for temporary foreign workers to gain permanent resident status. So FIDWAM has actually played a really formative role in pushing for some of the legislative protections for migrant workers in the province. And while the private sector home care services are proliferating, Manitoba has the most centralized home care system in Canada that provides a relatively comprehensive range of home care services provided by a unionized workforce. So the Conservative government that was elected in 2016 has been committed to privatizing this hard-won public unionized home care infrastructure in Manitoba. And despite these progressive measures historically, COVID-19 disproportionately impacted immigrant communities in Manitoba, and the programs and policies put in place to help frontline and essential workers left out key sectors that employ many immigrant workers, such as home care and food processing. So our small project represents, I believe, one of the first attempts to investigate the unique challenges experienced by immigrant home care workers in Manitoba. And crucial to the success of this exploratory research has been our partnership with the migrant justice group Migrant Manitoba, and employing a community-based participatory research process to connect with this hard-to-reach population and help us build connection and community among these fragmented and isolated workers. So we asked two central questions in our research. Who are immigrant home care workers in Manitoba in terms of their countries of origin, career trajectories, gender, race, etc., and what are their employment relations with older clients and their families? So by employment relations, I mean things like their ability to negotiate scope of duties, their employment documentation, forms of compensation, scheduling, things like that. And how have these workers and the services they provide been uniquely impacted by the pandemic? So I imagine that most of you are familiar with Migrant Manitoba. They're frequently in the media and have been at the forefront of efforts to support migrant workers in Manitoba during the pandemic. But I just thought I'd present a few facts here. Migrant Manitoba is part of both national and international alliances that support migrant workers and efforts towards addressing the roots of migration and fighting for the regularization and welfare of migrant and undocumented workers. Migrant is also largely unfunded. It's primarily a volunteer member-driven organization. And, during the pandemic, widespread recognition of the disproportionate impact that the pandemic has had on migrant workers has resulted in some provisional government funding to support migrant communities. And Migrant has been able to access some of this funding. However, it is short-term funding and it has strings attached. With Migrant's help, we conducted qualitative interviews and surveys with 18 immigrant home care workers. And in order to participate, we had some inclusion criteria that included that they had to provide care in the home as opposed to a residential care facility for someone 65 or older. They had to be employed during the pandemic and within 6 months of the interview, and they had to be born outside of Canada. So they're pretty broad inclusion criteria, but we did adjust it later on to recruit workers who lived and worked in more precarious situations. So people working outside of the unionized WRHA context and people who were more precarious, with more precarious statuses, or people who worked outside of Winnipeg. We also interviewed 7 key informants representing those with experience serving, leading, and organizing immigrant workers in Manitoba. And we collected data through an anonymous survey of 15 settlement workers and conducted a review of historical, organizational, and policy documents shaping the experiences of these workers. In terms of countries of origin, we had most of our workers were from the Philippines, so 14 out of the 18, the group of 18. The rest were from Guinea, Chile, India, and Sudan. And this isn't really an accurate representation of home care workers in the sector. We had a lot of difficulty recruiting home care workers for this project, and we did rely quite heavily on Migrant, Manitoba to help us with this recruitment. And because of their strong relationships with the Filipino community, we really had a disproportionate number of Filipino home care workers in our project. We had about 83% women and 17% men. And this is a little bit more of an accurate representation of the gender distribution of home care workers in the sector. We also broadly defined home care work as anyone doing essential care or support work that enabled an older person to stay in their home or in a community-based setting rather than being moved into a residential facility. So this allowed us to survey a wide variety of different types of work relationships. Most of the people we interviewed, I guess, the largest category was people working for nonprofit agencies, serving people in their homes or sometimes in a kind of an assisted living arrangement. 2 were privately hired with public funding. This is typically through the Self and Family Managed Care program, where clients or their families can access public funding to hire workers privately in their homes. 2 other workers were privately hired with their own funding, with private funding. 2 workers worked for a for-profit agency, and 2 others worked in a staffing agency, a temporary staffing agency. There was 1 live-in caregiver who was in that live-in caregiver program. She was on a 2-year work visa. And 1 was in a category that we were actually not quite sure what to call it. It's listed as other there, but this person had a live-in home care work relationship with her client. They had a written contract, but she actually wasn't paid monetarily. So she was paid in kind with, room and board, use of the client's car, things like that. So that was kind of a unique situation. So, and through this small sample size of 18, you can see that there are a lot of different work relationships and situations that immigrant home care workers find themselves in. Many of the workers were working in multiple jobs and sometimes in different types of relationships. So some were working in both the public and private systems. This is an interesting to kind of show this pie graph and this variation, because right now there's really only systematic data on people working in the public sector. So all of these private relationships that are outside of, say, for example, the WRHA or the regional health authorities is not currently in any kind of statistical data. And this also didn't even include this growing practice of hiring companions. So these are people that can work in the home, but they can also be hired from by a family member to care for somebody in a residential facility, but they're not actually, they're not hired by the facility, they're not regulated by the facility. So they're working in facilities, but not, there's no kind of policy regulating them. So we weren't able to capture that, but that's something we'd like to explore in the future. So you can see how diverse these work relationships are. A huge theme that ran across our interviews was how much their work intensified during the pandemic. They really highlighted a lot of different forms of exploitation. 82% of the workers said they weren't compensated for the work, for working beyond scheduled hours. There was a lot of instances where people stayed later to wait for the next shift, or they were covering for another worker. On top of this, a lot of workers had more than 1 job. As I mentioned, 12 people had 2 jobs. 1 person had 3, another even had 4 jobs. 11 people had 2 jobs. And of those 11, 5 were working outside of the caregiving sector. Some of those jobs outside the care sector were in the service industry. Some of them were working as in security or in restaurants or food services. Most of the workers worked around 40 hours a week, even though they were usually categorized as casual workers. They didn't have a full-time status in their workplace. But many worked more than 40 hours. 3 worked 50 hours a week. Another worked 70 hours a week. So you can see how intense and how much these workers are working to make ends meet during the pandemic, and again, not in the same workplace. We have some data and numbers to reflect some of these experiences, but of course, the data themselves or these numbers don't actually reflect the severity of the situation of being overworked. Even getting to work was challenging for many workers. They often spent hours in transit every day getting to and from their jobs, or commuting between their jobs or clients' homes. Sometimes they use cabs to get to and from locations, but they had to pay that out of pocket. A huge problem was that many workers shared was the mental load. So even when they're not working or commuting, they're thinking about their clients. So these are very intimate relationships, and they're often working one-on-one with a client, doing intimate care. And often because of the work shortages and the strains of the pandemic, they knew that their clients weren't getting the care that they needed often when they weren't there. And so they were constantly worrying. And so they talked a lot about carrying that mental load home with them. It was also very difficult for them to create boundaries because of this. They were often worried, who would do this if I don't do it? So they were often pushed to kind of take on those extra tasks that they felt no one would take on if they weren't there. Because most of them were categorized as casual, they didn't have access to things like vacation, sick days, paid time off, anything like that. So burnout was a very significant factor, and also just constantly feeling like they're on call. They could almost never take time off to rest or recharge. So in the next few slides, I'll kind of go through some of the more in-depth stories and some of the 3 challenge areas that we identified in our research. So systemic exclusion, we did a provincial policy scan, which highlighted how many Manitoba immigrant home care workers were either explicitly or implicitly excluded from both provincial wage top-up programs and the paid sick leave program. So the short-lived caregiver wage support program excluded all workers in private settings, which basically meant that none of the home care workers had access to this wage top-up. And indirectly, many of the migrant workers' families were also employed in the food processing sector, which was excluded from the risk recognition program. And such exclusions are alarming, given that these programs relied on federal funding that was earmarked to support essential workers. And of course, all of these workers are classified as essential. So why were they excluded from these income supports? And also, while the provincial paid sick leave program is technically available to all non-federal employees in Manitoba, it's voluntary and employer-driven. So that means that the onus is on the employers to offer the program to workers. Particularly in the private sector, workers are rarely informed about the possibility of accessing this pay. More than half a year after the program was implemented, none of the workers that we spoke to were informed about their eligibility for this pay. So most of them basically were not accessing extra support to take time off when they were sick. Another common and resounding theme in our key informant interviews was Manitoba's meager organizational infrastructure to support immigrant workers. Manitoba has no Workers' Action Center or Migrant Resource Center. Settlement services for migrant workers are extremely limited, and case support is limited often to organizations like Migrant Manitoba, which is largely unfunded. There's no gender-based approach to supporting precarious migrant or immigrant workers in the province. Historically, the Filipino Domestic Workers Association in Manitoba that I mentioned earlier has been a strong advocate for live-in caregivers, but FIDWAM is now largely inactive. During the pandemic, this lack of infrastructure made it difficult to respond swiftly and effectively to the needs of migrant communities in Manitoba. So there were, many of you are familiar with the government commissioned report that provided race-based data on the impact of COVID-19 in Manitoba that found that the Filipino community was the hardest hit of any ethnic or racial group in the province. Yet the province largely failed to develop a targeted COVID-19 response to better serve migrant workers and newcomer communities. We interviewed NDP critic on women and immigration, Malaya Marcelino, and she talked about how this community lacked a seat at the decision-making tables. And she flagged the First Nations COVID-19 task force as a model for immigrant communities to follow to improve crisis responses in these communities. So I just highlighted a quote from the interview here. So as mentioned earlier, privatized forms of home care are proliferating in the province, and I've listed some of the forms here, things like gig-based companies, temporary staffing agencies, proliferation of private agencies, or people augmenting their private home care services with government funding through the Self and Family Managed Care program. And so since 2016, the Progressive Conservative government has really prioritized this privatization, and while also limiting funding for settlement services and eroding employment standards. So this private sector work has virtually no oversight. We noticed that precarious working conditions, as well as race and gender-based violence, seem to be more prevalent in the private sector. And so we really felt that tackling this exploitation and violence is tied to struggles for public ownership and control over our home care systems. The creep of home care privatization is facilitated also by existing issues in the public unionized home care system. So during the pandemic, mandated overtime hours and staffing shortages, as well as lack of control over their schedules, have pushed many workers to leave for sometimes better paying jobs in the private sector. So Angel, one of our participants, was categorized as a casual healthcare aide in the Regional Health Authority, and felt profoundly burned out after two years of what really felt like nonstop work during the pandemic. Despite her casual work status, she typically worked more than 40 hours a week and was often on call or compelled to work overtime. While having strong relationships with her clients, and this is often cited as an advantage for both workers and clients, in the case of profound burnout, she felt burned by these relationships. She knew her clients weren't getting the care that she needed, and she carried these worries home with her. She felt guilty about declining shifts, even though she wasn't well. Many of her coworkers were being recruited by temporary staffing agencies that were proliferating because of staffing shortages during the pandemic. And she finally decided to quit her unionized job to work for the staffing agency. While she lacked guaranteed hours, benefits, and protections under Manitoba's employment standards, she felt that she finally had control over her schedule. She could take time off when she needed to, and she didn't have to worry about losing her job. The chronic staffing shortages meant that there would always be work for her to pick up. And if she didn't like a client or a home care agency, she could simply choose not to take shifts there, or she could work elsewhere. She said, as a temporary worker, she said, I can finally rest my body so I can have a baby. If I'd known about the temporary agency years ago, I would have worked very hard for them for a month, and then I would have taken time off for 3 months in the Philippines, and you're okay. So she's saying, I don't have to worry about losing my job. So this was one way that workers asserted agency and even resistance in the pressure cooker of working in failing home care systems as immigrant workers during the pandemic. I also wanted to just highlight some other forms of resistance during the pandemic that took place on multiple scales. I think that's really important to emphasize. On a large scale, our community partner, Migrant Manitoba, served workers by developing a mutual aid program called Kapit Bisik, which means linking arms in Tagalog, to support migrants in Manitoba. They've delivered close to 1,000 food hampers to workers and are beginning to distribute test kits and personal protective equipment. We heard time and time again that Migrant has relied on government officials and service providers alike, or Migrant is relied upon rather by government officials and service providers to find ways of reaching migrant workers and supporting them during the pandemic. And through their networks, they have a strong understanding of worker issues and can demand policy change. So we hope this research that we're conducting, that we're presenting now, will be part of those critical community-led efforts. And then on a smaller scale, workers also stand up to various forms of racialized and gendered discrimination and sometimes even violence that they experience in home care users' homes. For example, workers like Florabeth, who works for the unionized Winnipeg Regional Health Authority, often goes above and beyond to prepare nutritious food for their clients in their homes, but they sometimes hear complaints about foreign foods and dishes that they prepare. And some workers tell us that their clients don't want them to touch their food or anything in their kitchen. And so Florabeth was kind of talking about how, she navigates situations like this. And she said, this is our culture, and our clients, in some ways they need to get used to it. And they're finding ways, often on their own or through the support of family and other immigrant community members, to express themselves in these jobs and make long-term careers in Manitoba's home care system. And so I think, I'm going to talk a little bit about the importance of supporting those types of efforts on a more structural level. So I'm going to propose a few responses to these issues, and I'm looking forward to hearing feedback in the comments or in the chat. So during the pandemic, as I said, pervasive policy exclusions, dangerous, precarious, and even sometimes violent working conditions have made these workers feel disposable and unappreciated. And in the short term, I think government, unions, home care agencies, and community organizations can run campaigns about these issues, pointing to the valuable and essential role that these workers play in our healthcare system and the need for them to be properly paid, supported, and recognized for the valuable work that they do. In particular, the gender and race-based violence in this sector is an open secret, I think, in Manitoba, and we need campaigns, media, and education that address this directly. The next two short-term solutions that we're proposing are policy demands. So obviously improving the working conditions by providing living wages, job security benefits, protections. And I think coming out of our research, what is really, really loud and clear is the need for time off and control over scheduling and sick leave, recognition, respect, and proper settlement supports for newcomers working in this field. And so I think this is really essential for stopping. Right now, we have a kind of a revolving door situation in the home care sector where workers are getting burned out and they're leaving very quickly, even if recruitment efforts are ramping up. And so, in order to retain workers and improve the quality of home care services, I think these addressing things like time off, control over scheduling, improving wages and job security is really, really essential. And it's hard to imagine how we can do these things through the private sector. These changes require commitment to universal funding, and they also require regulation and workforce planning that can only be done by government. So, and finally, precarious immigration status endangers workers in so many ways. So regularizing all migrant workers in this sector and ensuring strong pathways to PR, and these are things that Migrant is already campaigning for. These are really essential to providing the supports that these workers need quite urgently. In the medium term, there's virtually no oversight over the home care sector outside of the public unionized health authority. So we need systemic data on who these workers are, what their training is, their scope of duties, pay, etc. This data is essential for developing organizational infrastructure to support these workers, make demands for adequate funding. Right now, we don't even have accurate estimates of how much funding is needed. They need credential recognition. And this data can also help hold employers accountable when labor standards are violated and organize for evidence-based policy change. And we thought a mandatory home care employer registry would help provide this data. And then also tackling private for-profit models of home care delivery goes hand in hand with efforts to have more oversight and legislative protection and enforcement for these workers. So one cannot be done without the other. And again, universal public funding of these essential services is critical for improving this care and the quality of the working conditions for these workers. And then finally, in the longer term, these ideas are kind of built on kind of conceptual shifts in the way that we think about home care. There's been a lot of talk in some circles about deinstitutionalizing long-term care. But I think there's a lot of deficiencies in our current home care systems too, that really highlight how these home care systems, while they're not in residential facilities, you know, this is a home-based model, they're still very institutional in character. They're top-down approaches that leave no room for personalization or engagement or participation from clients and family caregivers and direct care workers, let alone thinking about things that I think we need to move towards, like client worker control and solidarity in this sector. And to deinstitutionalize home care in the long term, we need public and community-driven ownership models of these systems that are capable of addressing inequities along the lines of immigration status, gender, race, disability, age, and sexuality, just to name a few. And so this is a bit academic, but I'm happy to discuss more or answer questions. We've been really compelled by this model of intimate community unionism that's been proposed by Cynthia Cranford to support both precarious workers and low-income disabled and older care recipients. So this model, which I kind of sketched out here, pushes the current public union model to be more community-driven and engaged with the intimacies of the home care labor process, and the need to balance flexibility for clients with security and decent work for immigrant workers. And fundamental to this is the universal public funding that I keep emphasizing over and over, and worker recipient state-funded labor intermediaries that are culturally sensitive. And such a model moves us towards more of a grassroots coalitional engagement with home care systems rather than the top-down institutional and bureaucratic approach that is so prevalent right now. So with that, I'm happy to get your feedback and questions, and I'll just put up some contact information here if you're interested. I can also send out a PDF of the presentation, and some of the references that I've cited there are included. So I'll leave up the contact information for now. Thank you so much.
Thank you, Dr. Hande. So there are some questions on the chat area here. The question is first is about what was the common obstacle for those workers to get home care job?
Sorry, I didn't catch that one in the chat, but a common obstacle to getting home care jobs. Oh, I see it here now. Yeah. Thank you. I mean, to be honest, there weren't a lot of obstacles to get jobs. I mean, there's such a labor shortage in these jobs that it was actually, especially outside of Winnipeg, if you're working in a rural area, a lot of workers found it easy to find work in this area, whether it's through working privately for a family or even sometimes even for a public agency. Several of the workers that we talked to outside of Winnipeg said that they were able to start working even before getting their healthcare aid certification, because there was as long as they were committed to going through that training at some point, there's such a shortage that they were able to get started right away. Yes. So I mean, it wasn't really a focus of the research project, but I don't recall a lot of workers explaining obstacles getting these jobs. I guess getting into the WRHA or a regional health authority position is more difficult. And I know a lot of workers talked about, really trying to get in there. But I mean, yeah, we didn't, especially with like extensive job experience. A lot of workers didn't struggle getting those jobs. I think the biggest thing was it was hard for them to get the full-time status in like a with the WRHA or, in other regional health authorities, and to actually get those benefits and protections. So most of the workers were casual and didn't have those types of benefits.
Thank you. Another question here is, other studies have been shown workers have felt they had the white PPE were less stressed. So did you ask about what the workers got the PPE, and then were they given the real respirator or medical mask? Were they told why? Were they being told this is the virus is airborne?
We did ask some of the workers about their access to PPE. I think it was for most of the workers, they did have PPE months into the pandemic, but in the early stages of the pandemic, it was definitely, for some of the workers, it was hard for them to access adequate PPE. And so that was quite stressful for them. I think it was, in those first few months of the pandemic, it was a lot more chaotic. And there wasn't a lot that was understood about the transmission of the virus. So, they were also getting a lot of pushback from their clients about, how to protect their clients from the virus, things like not wanting to be touched, before people understood that it was predominantly airborne transmission. I think a lot of clients didn't want their worker, like they were canceling shifts with their workers, or they didn't want to be touched, or they didn't want their food touched by the workers. And the workers were also struggling to access PPE. But as the pandemic, we conducted interviews for over a year. And so later on in the pandemic, the access to the PPE wasn't as much of an issue for most of the workers. And the clients, I think, also started to realize that they couldn't turn down those services for long periods of time. And so a lot of those issues, I think, were kind of alleviated a bit. I think, I hope that answers that question.
Yeah, thank you. So this is a comment saying that definitely we need changes in the healthcare position, right? Should work directly with these employees, and often find they were injured as a result of the overworking and different situation. So they encounter on a daily basis. So definitely, the home care system, probably we need to get some changes for sure, right? And another question is all about the respirator and the mask too. So if some worker given the N95 respirator, will they be fit tested prior to using the N95 respirator? Do you have any questions on that survey?
Actually, we don't have data on the types of, I don't think any of the workers described having respirators, but I don't have details on the fit, like if they were fit tested. We didn't go into a lot of detail about the specific PPE that they received. Most of the workers, I think, especially because a lot of them are in private settings, and some of them are they're being hired directly by their clients. It's whatever their clients are purchasing for them. So I don't think it was, it was certainly the type of PPE that they had access to was not uniform across the interviews. So I'm also seeing the comment here about occupational health folks knew the virus was likely airborne from the beginning. So that, yeah, I don't know that a lot of workers, I think workers, like they were talking a lot about things like feeling like they needed to isolate from their families for a few hours when they came home from work, because they were worried, like they would, shower, and they were anxious about spreading the illness to their family. They were anxious about taking transit to and from work. But unfortunately I don't have like a systematic understanding of the types of PPE that they were using across the interviews. Okay, I'm also seeing the question here about the sample size and future research plans. And how many home care workers are impacted by the issues outlined in this study in Manitoba? I mean, so I'll try to answer those things. So yes, it is a small sample size. Like I said, we did have a lot of problems recruiting, and we were really trying to recruit as many workers as we could that were outside of the public sector, which made recruitment more difficult. We do plan to scale up the research. We're working on a new research project that will include Ontario and Manitoba. And this one will be more geared towards home care system transformation. And of course, we'll probably work beyond. I don't know when the pandemic is going to be over, but it will likely be unfolding for the next 3 to 4 years. But we're still applying for funding for that research. And how many home care workers are impacted by the issues? I mean, this is a really tricky question because I mean, this is kind of related to what I was saying about the lack of data. I mean, there's just no systemic data on the workers in the private sector. So I don't even know that beyond like just looking at job postings or getting information from agencies, which is very difficult, private agencies. I don't think we have like a clear understanding of how many workers are actually working in the private sector right now. And so that's part of the issue. And I think getting something like a registry, like an employer registry, where we can actually track that information will give us a better understanding of how many workers are actually needed in the system and how many people are actually working in the system right now. And also, trying to get a better sense of how many, like what the difference is, like what when we're talking about recruitment, when we're talking about expanding funding for these services, I mean, how much money do we actually need? How many workers do we actually need to recruit? I don't think we have like a really clear sense of that, particularly because of this sprawling private sector. I'm sorry that I don't have like specific numbers, but I think that's part of why the research is exploratory, why the sample size is small, is because the research on private sector home care workers is very minimal right now, and we just don't have that data. I'm just reading through the comments right now. Yeah, so I'm seeing, I hope I'm pronouncing your names, Zarina's comment here, that definitely was comparing the WRHA and the private agencies. That definitely came out in the interviews, and that, I highlighted that quote by that was made from Angel, the worker that we interviewed, who left the public system to go to the private temporary staffing agency. Because of exactly what you're saying, she felt so stressed and so overworked in the public system, and she felt when she moved into the private agency that she had more control over who she could work with, how many hours she would take on. She could take time off if she needed to. And I think this is how the private sector is, it's not only the working shortages, but they're offering things that the public sector isn't right now. They're offering, in some cases, higher pay. They're offering more control over their clients or who they're able to work with. I'm just seeing here, I think there was only one worker in our sample that had full-time status. So this is an answer to Renee's question. I think that there was only one worker that was categorized as full-time. The rest were casual. Not all of them worked full-time hours, but many of them worked full-time hours, or they were working full-time, like 40 hours, and then they had, additional jobs in sometimes in other home care settings or in the service industry, in addition to those full-time hours. But I think only one of them was formally categorized as a full-time employee. Yeah, I'm seeing Peter's comment about the catch-22. Yeah, so I remember asking that worker, are you concerned about not having access to things like employment insurance or benefits, or even, like, being, being in the like access to employment standards, like being regulated by employment standards. And she said, yeah, it's a concern. I'm worried about health. I'm worried about access to healthcare. I'm worried about, what happens if I get injured in the workplace. But she said she was so burnt out. She said she really just wanted to take time off, like an extended period of time off. She wanted to have a baby. She wanted to go visit her family in the Philippines, and that those desires outweighed her need for, the employment benefits. I'm seeing here the need to continue to wear masks. I totally agree with you. Yeah, I don't know if anyone else has any other questions. I'm sorry, I recognize a lot of people have really in-depth knowledge here about PPE and health and safety protocols in the workplace. And that was definitely something we discussed in the interviews, but it wasn't the focus of the interviews. We were mostly trying to understand what were the biggest concerns for workers. And usually it was that they didn't have job security, and they didn't have time off. They didn't have adequate wages, things like that.
Yeah. Do you have any more questions and comments you want to express it on the chat here? So yeah, we appreciate, all the participants and really engaging, putting the comment and questions on the chat area. So yeah, I'm sorry for cut you off.
Oh, I'm just seeing here Renee's comment again.
Yeah.
I mean, I obviously that's, some workers, like not all workers are willing to risk losing the benefits of having a union and workers' compensation if they need it. But I think the lack of control over their work schedules is really, really burning a lot of workers out. And the workers did tell us, this is obviously somewhat anecdotal, but that they see lots of workers making the same decision. And I think what Angel told us was that she wished that she had followed the other workers sooner to the temporary staffing agency and left that position with the health authority sooner. She felt like she felt foolish for staying with the health authority, which was actually quite alarming.
Mm-hmm. I saw the last questions here from Dorothy. What differences might you have been seeing other racialized workers?
Could you clarify the question a bit, Dorothy? Do you mean like, what do you mean by other racialized workers? Like, you mean non-Filipino workers, like differences? Is that what you mean?
She said that you said it was mostly Filipino workers. Is that yes?
It was mostly Filipino workers. Yeah, I mean, we only interviewed 4 workers that weren't Filipino, so I don't think that we could really, we can't make any broad statements about differences between Filipino and non-Filipino workers. I think just, again, like, this is mostly anecdotal. This is, an exploratory research, but it was interesting. The worker that we interviewed from Sudan talked a lot about specific anti-Black racism in her workplaces, and she worked both for a private agency and for the WRHA. She felt that it was, there was definitely she experienced more racism when she worked in the private agency, for sure. But she noticed that she felt that she was actually hired, the agency was predominantly Black. She felt that she had been hired because she was Black. And she was reflecting that she felt that some of the private agencies were really catering to some of the preferences of the clients in terms of what type of worker they would like to work with. And so she felt that, perhaps some agencies were catering to different racial preferences of their clients. And that was something that was very stressful for her. She said they had like an anti-racism or a zero tolerance for racism policy in her workplace, but she said it wasn't enforced. When she complained about racism, she felt that she didn't get any support from her employer. And she said she didn't have those issues weren't quite as pronounced in the public sector. So again, these are, stories from the workers. I don't want to generalize them, but they're interesting insights into how workers experience, and navigate these types of issues in the workplace. I guess the other thing I would mention is just that I think the Filipino workers are, they have most of the workers feel isolated and invisible, like I said earlier. But I think that the Filipino workers, there are organizations that represent Filipino workers in Manitoba, organizations like Migrant or FIDWAM. So I think in general, you could say that those workers have, they're more likely to have those kind of organizational supports. But of course, Migrante doesn't serve only Filipino workers, they serve all migrant workers. But I think that the Filipino networks are perhaps more developed. I don't know if that answers your questions.
So once again, on behalf of the Occupational Health Center, thank you so much, Dr. Hande, for such a great presentation. So yeah, this is a really great research project we have been putting on, is all the finding to share with us, explaining what's the assistance and challenges of the home care worker facing it right now, and making some recommendation. This is really, really good. We want to see. So thank you all of you for joining the presentation here. So so the presentation will be sent out with the PDF version and also the record session. So that please check your email. So hope you all have a great afternoon. Thank you so much.
Thank you so much. Bye.
Bye.